Welcome to the Informed Woman magazine, where science meets clarity and knowledge becomes strength. I'm William Bologna. Let's make women's health understandable together.
PCOS is not a simple hormone imbalance. It's a body-wide communication breakdown. Your metabolism, ovaries, and brain start amplifying each other's signals until the system spirals out of control. The result? A loop your body cannot escape on its own, unless you understand where it begins. The first disruption begins in the brain, with the GnRH pulse generator firing too quickly. Faster pulses mean the pituitary releases more LH than FSH, an imbalance that tilts the entire reproductive axis. This is the first domino in the PCOS cascade. Excess LH drives the ovaries to produce more androgens, far more than they should. Meanwhile, low FSH means follicles never receive the signal they need to mature. Two problems form at once: too many androgens, too few mature eggs. Instead of one follicle rising to become the egg of the month, dozens get stuck. They remain in arrested development, alive but unable to progress. This is the origin of the polycystic appearance on ultrasound. Without ovulation, progesterone stays low, and that matters. Progesterone is the hormone that normally slows the brain's GnRH pulses. Without it, the brain continues firing in high-speed mode, reinforcing the hormonal imbalance. So the system becomes a loop. Fast pulses raise LH. High LH raises androgens. No ovulation lowers progesterone, and low progesterone keeps the pulses fast. A perfect storm, locked in place. But here's the twist. Insulin resistance often makes this loop dramatically worse. When cells stop responding to insulin, the body releases even more of it. And high insulin supercharges ovarian androgen production. Insulin amplifies LH's effects, telling the ovaries to produce even more testosterone. It also lowers SHBG in the liver, increasing free androgens circulating through the body. This is when symptoms begin to appear visibly and physically. Excess androgens affect everything: your skin, your hair, your cycles, and your metabolism. This isn't cosmetic, it's biochemical. Androgens disrupt normal follicle development, making ovulation even more difficult. Layered on top is inflammation, another amplifier. Inflammation worsens insulin resistance, which increases androgens, which worsens inflammation. PCOS is not one imbalance. It's many loops feeding each other at once. Once these loops start accelerating, your reproductive system cannot reset itself. The rhythm that should guide each month becomes distorted. Regular ovulation becomes the exception instead of the rule. Now the overlooked player, AMH. Women with PCOS have 2 to 4 times more AMH than average. And this isn't just a number on a blood test. AMH directly shapes ovarian behavior. High AMH reduces follicle sensitivity to FSH, making it harder for any of them to grow. This deepens the follicular arrest, keeping development frozen. AMH even boosts theca cell responsiveness to LH, meaning androgens rise even further, reinforcing the PCOS environment. And new research suggests AMH may speed up GnRH pulses directly. This links elevated AMH to the very neuroendocrine dysfunction that defines PCOS. It's not just a biomarker, it's an active participant. Once these hormones fall out of rhythm, the entire reproductive axis destabilizes. The brain, ovaries, and metabolism stop communicating clearly. The result is chronic anovulation. Ovulation depends on timing, and PCOS breaks that timing at multiple levels. This is why cycles become unpredictable, long, or absent. It's not randomness, it's physiology. PCOS feels overwhelming because everything is connected. Fixing one part requires understanding the whole system. This is a disorder defined by loops, not single triggers. But here's the empowering truth. Loops can be interrupted, and with the right strategy, the system can be reset. But you need to know where to begin. In part 2, we reveal how to break these PCOS loops, step by step. And one new therapy may transform how we treat PCOS entirely.
If PCOS is a self-reinforcing cycle, then treatment is about finding the leverage point. the moment where one small change reshapes the entire system. The right intervention can shift your metabolism, hormones, and ovulation all at once. The foundation of PCOS treatment is lifestyle modification, and it is far more powerful than most people realize. This is where the hormonal loops begin to loosen. A 5 to 10% change in weight can reset key signals. A diet based on whole foods, lean proteins, low glycemic carbs, and anti-inflammatory fats stabilizes insulin. And when insulin stabilizes, androgen levels drop. This is the first place many women feel the shift. Exercise compounds the effect. Both resistance training and aerobic activity improve insulin sensitivity independently. Movement becomes medicine for PCOS. For irregular cycles, combined oral contraceptives are often the first-line therapy. They regulate bleeding patterns and lower ovarian androgen output. The cycle begins to regain its rhythm. Lower androgens mean clearer skin, less hair growth, and smoother cycles. This is not masking symptoms, it is restoring equilibrium. For many women, this alone creates meaningful transformation. When pregnancy is not the goal, cyclic progesterone protects the uterine lining. It prevents overgrowth caused by unpredictable bleeding. This preserves long-term uterine health. Metformin addresses the metabolic engine behind PCOS. By improving insulin sensitivity, it indirectly improves ovulatory function. Its effects accumulate over time. When androgens remain high, spironolactone can help, but it requires careful contraception. It reduces acne, hair growth, and androgen-driven symptoms. It is not a standalone solution, but part of a broader toolkit. For women trying to conceive, letrozole is now the first-line ovulation inducer. It works by lowering estrogen just enough to stimulate FSH release. This helps select a dominant follicle. If letrozole fails, gonadotropins or minimally invasive ovarian drilling may be used. The goal is precision, not overstimulation. Every follicle is guided carefully. IVF becomes essential when other methods don't work. But PCOS requires a uniquely tailored approach to avoid OHSS. Everything must be low, slow, and deliberate. Mild stimulation, antagonist cycles, and agonist triggers reduce risk dramatically. This approach nearly eliminates OHSS while still producing viable eggs. Safety becomes the priority. IVF also lets embryologists select the healthiest embryos in the lab. This bypasses issues with irregular ovulation or hormone timing. Technology compensates where physiology struggles. Most PCOS patients benefit from frozen embryo transfers. The uterine environment is calmer, more receptive, and hormonally balanced. This improves pregnancy success rates. Acne, hair growth, and hair thinning often require targeted treatments. Dermatology and endocrinology work together here. These symptoms are reflections of internal hormonal shifts. PCOS increases the lifetime risk for diabetes, metabolic syndrome, and cardiovascular disease. This is why ongoing monitoring is essential. Treatment is not just about fertility, it's about long-term health. Here's the part almost no one talks about: NK3 inhibitors. They target the brain's pulse generator and slow GnRH pulses. This restores the LH-FSH balance at the root. By calming these neurons, NK3 inhibitors reduce LH output and lower androgen production. This is a non-hormonal therapy with profound potential. It acts at the origin point of PCOS. Early studies show improved ovulation and reduced androgen symptoms. For many women, this could be a paradigm shift in treatment. We are beginning to treat the signal, not just the symptoms. But the deepest question remains: why did this system misfire in the first place? In Part 3, we explore the epigenetic forces that may program PCOS long before symptoms begin, sometimes even before birth.
What if PCOS doesn't start in adulthood, or even in puberty? What if the earliest instructions were written into your biology before you were born? Epigenetics may hold the key to why PCOS develops in some women and not others. Women with PCOS show widespread differences in DNA methylation across ovarian, muscle, fat, and immune cells. These marks change how genes behave, without altering the DNA sequence itself. They tune your biology before hormones ever appear. In the ovaries, hypomethylation makes theca cells hypersensitive. They overproduce androgens even when signals are normal. It's like the volume dial is permanently turned up. Other epigenetic patterns affect insulin processing in fat and muscle tissue. This contributes directly to insulin resistance, a hallmark of PCOS. These metabolic imprints can persist for years. Epigenetic marks also affect follicle development. They alter AMH signaling and disrupt granulosa cell function. This shapes the very architecture of ovulation. Histone modifications add another layer of control. They determine how tightly DNA is packaged, and therefore which genes are active. This influences everything from androgen production to metabolism. And here's the striking part. These epigenetic patterns may begin in the womb. A mother's hormones, weight, and insulin levels can influence her daughter's future reproductive biology. This is developmental programming. Maternal hyperandrogenism or insulin resistance may imprint epigenetic marks on the developing fetus. These marks affect organ systems before they are fully formed. This risk may pass silently across generations. Even before puberty, daughters of women with PCOS show altered metabolic and hormonal patterns. Their biology is already primed for PCOS. Environment shapes susceptibility long before symptoms emerge. MicroRNAs add a third layer of epigenetic influence. They control which proteins get made and which don't. Dysregulated microRNAs in PCOS alter insulin sensitivity, androgen production, and follicle health. Together, methylation, histone modification, and microRNAs form an interconnected system. This system shapes metabolism, reproduction, and inflammation simultaneously. It is a blueprint that evolves over a lifetime. But here's the good news. Epigenetic marks can change. Weight loss, specific diets, and exercise modify methylation patterns. Your choices can literally rewrite biological instructions. Metformin has epigenetic effects too, altering gene expression in metabolic tissues. It is both a metabolic therapy and an epigenetic influencer. This is one reason its benefits extend beyond blood sugar. New research is exploring epigenome editing. Tools like CRISPR-Cas9 can add or remove methylation at exact locations. This could one day correct PCOS-related epigenetic marks directly. Scientists are also developing microRNA therapies. These strategies aim to rebalance gene regulation at the post-transcriptional level. They target the logic of PCOS, not just its symptoms. Oocytes themselves carry epigenetic memory. Some PCOS signatures may pass from one generation to the next. This raises profound biological and ethical questions. In IVF settings, researchers have detected distinct PCOS epigenetic patterns in early embryos. Future technologies may help identify or even correct these patterns. But these ideas remain exploratory and deeply sensitive. Epigenetic therapies carry enormous promise, but also enormous responsibility. Safety, specificity, and intergenerational effects must be fully understood. This field is advancing carefully, step by step. The message is clear. PCOS is not your fault. It is a biological landscape shaped by genetics, environment, and early life conditions. But with knowledge comes agency. Your epigenetic markings are not destiny. They are responsive, adaptable, and dynamic. With the right interventions, you can reshape the signals guiding your reproductive health. And this series is just the beginning of understanding your body in full.
Thanks for watching another video by the Informed Woman magazine. Please feel free to comment and ask questions. Subscribe for more science-driven medical insights.